the land acknowledgement. It's Alec McKenzie. If for people keeping track at home, I was the host last week. I think Pranesh wants me to keep on doing it till I get it right. I'm not sure what the thinking was. Also, I know both Neal and Kristin. Maybe that was it. Anyway, Alec McKenzie here to host today's very exciting, interesting Grand Rounds. But first, I want to say that Ottawa was built on unceded Algonquin Anishinaabe territory. The people of this nation have lived on this territory for millennia, and we honor them in the land. Their culture and presence have nurtured and continue to nurture the land. We also honor First Nations, Inuit, Métis, and their past, present, and future contributions. So today we've got both Neal Sondheimer and Kristin. Neal, I was just getting a quick bio. Started off MD, PhD in Chicago, did important work on identification of prion variants in the yeast biology with a high-profile Howard Hughes investigator, Dr. Susan Lindquist, and then went on after that to CHOP and worked there, and then Toronto, and then a 2-year interregnum at a PKU company in Cambridge, Massachusetts, that he's promised to tell us about at some maybe future Grand Rounds or something. Back to Toronto for an interim, and then when Pranesh ascended to the lofty heights of chair of pediatrics, Neal was seconded to come and take his place running NSO in 2024. I think, Neal, that's largely factually correct. Kristin, who I've known longer, I first saw passionately explaining her poster on epigenetics in London, Ontario in 2013. She was a real standout. She came to my laboratory shortly thereafter to be a postdoc, stayed a few months, but then realized that Kim Boycott was where the action was, and went on to a stellar career there and has moved on to NSO. And among other things, her legacy is getting the spinal muscular atrophy newborn screening, first one in Canada going, and among many other things, which we're going to hear today. I just do a quick shout out to Pranesh Chakrabarty and Michael Garrity, who got this all going approximately a quarter of a century, 20 years ago, NSO, to set up one of the best programs and one of the largest programs in the world for newborn screening, a real CHEO success story. Pranesh very much regrets that he couldn't be here. At any rate, I will stop talking now and hand it over. I think you said alphabetically, Neal, is that right?
Okay, yeah, I'm starting.
Okay, good stuff. Welcome, Kristin.
Thank you. So today we're going to talk about a study that we're working on at NSO called the Infant Study. And certainly, like all, we've finagled an acronym. So it stands for Identifying At-Risk Newborns from the Analysis of NGS Testing. Okay, so super brief background. Newborn screening is a public health program which tests newborns shortly after birth to identify certain serious but treatable conditions before symptoms develop. So it ensures that babies receive timely interventions that can prevent serious illness, disability, or even death. In Ontario, nearly all newborns have samples sent to Newborn Screening Ontario. We're a provincial program located here at CHEO. Newborn screening in Ontario includes many components. So today we're obviously focused on the dried blood spot, but there's also other components. So critical congenital heart disease, which occurs at the bedside. Biliary atresia is a program partnered with Parents from Home, and hearing loss screening happens both in the community and from the dried blood spot. Okay, so one of the first key things is how are conditions selected for newborn screening? We obviously can't test for every disease, nor would it make sense. How do you choose which ones? And this was actually guided by principles from a long time ago. So Wilson and Younger in 1968 outlined these screening principles, and they're really still what guide newborn screening selection to this day. And so briefly, is it an important public health problem? Is there a treatment? Are there treatment centers available? Is it identifiable early in the symptomatic stage? Is there an actual accurate screening test? And is this test acceptable to the population? Do we know what the natural history of the disease is? And then finally, again, within a public health system, is there a cost of screening affordable? Does it make sense? And so in short, we test for disorders where early intervention before symptoms appear makes a significant difference. And so certainly this is the lens that gets applied then when we look at expanding newborn screening in the context of something like infant that we're going to talk about today. Okay, so Alex alluded to this, but the history of newborn screening in Ontario. So it actually began in the 60s with just PKU, and it was part of Ontario Public Health. Over the years, then there was additions to it, but slowly as part of public health. And then before my time, in 2006, there was a bid to actually establish newborn screening Ontario, and CHEO, Pranish, and Michael, as Alex alluded to, won this bid. And so newborn screening Ontario was established here at CHEO in 2006. And this really came with a large expansion of the number of conditions that were tested. And then they've been added steadily to this day. And you can see the timeline here. One of the key things to note, though, is that most of these conditions are metabolic and they're tested by mass spec. This is what allowed the explosion of the number of conditions that was tested early on, or there's other specific biochemical assays. We do have some genetic-based assays, but they're either not scalable for the number of genomic regions, meaning we can only test a few sites in a lot of people, or the throughput, meaning we can test a lot of sites but in a small number of people. And so for us to be able to do something like genomic newborn screening, we really need to be able to test a lot of sites in a lot of people. And so the technologies that we're using in screening right now won't be able to adapt to that. Why do we need this large adaptation? I'm sure you've seen many talks from others at CHEO working on great other NGS developments, but essentially with the advent of NGS, we were able to identify the molecular cause of many rare diseases, and with that came the development of treatments. And so you can see the scale of treatment development is quite quick, and this is us down here as the tortoise chasing the rocket. We need right now, we very, very methodically add one assay at a time as a new treatment is developed. This really won't be able to scale with the advent of gene therapies, and there's hundreds and hundreds that we know are in clinical trials, and hopefully many of those will prove to be successful. So with the pace of rare disease therapy, we need a way to be able to identify an increasing number of these rare diseases. And again, many of these are not metabolic, and so there may not be anything that's a signature we can test for. And so this led to the obvious question from many, which is, can we use next-gen sequencing for these high throughput screening assays? We are not the first to think of this. Certainly, this was actually a review from a couple years ago from 2023 from Zornita Sart in Australia. And at the time, these were the other genomic newborn screening projects. And I can tell you that they're currently working on redoing this map, and there's about 50 projects worldwide. All these projects have slightly different approaches in terms of how they selected genes, what their sequencing strategy is, et cetera. But essentially, this is something that's really full force across the world in many sites that they're trying to investigate how we could expand newborn screening using NGS. Okay, so what are kind of a few of the ins and outs of genomic newborn screening? They're not designed to replace the current screening that occurs with enzymology, mass spec, and other familiar techniques. They're actually designed to augment these or to offer a screen where screening is not otherwise possible. So there's some diseases that we screen really well. So an example is like PKU. You're not going to stop the small molecule screen. It's essentially 100% sensitive. We know genomics would not be 100% sensitive. You're going to have variants that we don't yet understand their impact. We call them VUSs, or perhaps intronic variants that we can't identify. But genomics certainly could offer additional information at referral. We know that certain genotypes respond well to certain treatments and others do not, and that could be additional useful information at referral. We have some diseases we screen right now. Cystic fibrosis is a good example where the screening's maybe not the best it could be. And so cystic fibrosis, we use first here is immunoreactive trypsinogen or IRT assay. And we know that this isn't perfect. And so we're choosing a certain percentage of the population that based on their IRT level is at risk for cystic fibrosis. And from there, we conduct molecular analysis. But if we could actually sequence first, this would likely be a superior strategy and would avoid some of the false negatives that we do have with our current strategy. And then finally, we have some diseases that we can't screen. And so there's some examples of monogenic hearing loss, perhaps as later onset, meaning it's not going to be picked up in the audiometric screening at birth, but that child will have hearing loss onset by the age of 5. And here, DNA testing options is really the only option at this point. Okay. Again, because other people have come before us, we can learn from them. And there's been a number of studies that have shown that generally this technology is acceptable and of interest to parents. And certainly parents are quite engaged in the newborn screening community, wanting optimal health for their children. Okay. So with that, when Genome Canada, about a year and a half ago now, announced their new set of grants that they were calling Canadian Precision Health Initiative, or CPHI, we wrote the infant study. And so the goal of this is to establish and evaluate a comprehensive genomic newborn screening program in Canada that integrates NGS to identify treatable rare diseases in newborns using the NSO population. And so we screen for Ontario, but also Nunavut, or parts of Nunavut, sorry, and Newfoundland. And so we are currently live, you'll see, in Ontario, but working on getting the other provinces on board. The objectives for our study, the first is to develop a genomic newborn screening approach. This includes developing our gene panel that we're going to test for, and then logic around how do you identify those infants that would be at risk. We're going to do this by whole genome sequencing. This is part of the CPHI study. This is essentially Canada's way to get 100,000 whole genomes. And so as part of this, genome technology is the one to use. We will perform genome sequencing of 9,000 infants from the general population. And then the third objective is to assess the sensitivity of genomic newborn screening using 1,000 participants that are screen positive from the standard of care newborn screening. And so this is things like PKU, MCAD, et cetera, that will give us information in terms of what is our sensitivity for those disorders, and how could this have been of use to the physicians treating them. And then finally, as part of the CPHI project, this data will then be contributed to the Pan-Canadian Genome Library. Okay, so a brief high-level overview. I don't know actually if you can see my cursor or not. So there's 9,000 infants from the general population that we will be recruiting through social media and other means. Or we then have 1,000 infants that were newborn screen positive, and these are being directly recruited from genomic counselors. Thanks, Neal. Cursor is visible. Neal's going to talk more about our recruitment strategy in the second half. So overall, parents are directed to our website. You'll see this as well. They complete our educational modules and then have the ability to provide informed consent in a platform called Genetics Advisor. At this point, the dried blood spot card is retrieved. So we are using residual dried blood spot cards. So the standard of care newborn screening has taken place. There's often some sample left. And so we're using that residual sample, and parents are consenting to use that. The card is retrieved, DNA is extracted, whole genome sequencing is performed. At this point, we assess for variants likely to cause one of the target diseases. Infants who are screen negative, it gets auto-authorized through our system. One of the key differences between diagnostic testing and screening is just the throughput. And so we have to come up with methods to be able to do this. Cases who have any chance of having a positive, so maybe there's a variant that looks interesting, there's a variant that we've seen before and no causes disease, et cetera, those will actually create a case for us to go in and look at. So it doesn't mean it's positive, but it creates a set of data that we then can go evaluate. The set of genetic counselors and scientists at NSO working on this. And at this point, positive results are communicated by phone to parents from NSO genetic counselors, and then there's a pathway downstream of that that's set up for treatment. And negative results are uploaded into our system so that parents can go and check that. Basically, if you don't get a phone call, check the system. At this point with the referral, we then also collect information back, and Neal's going to talk about this, to be able to evaluate our screen in the end. Okay, so briefly, certainly a project of this scale, we can't do alone. There's many, many partners. And so obviously starting on the left, we have Newborn Screening Ontario. There's the different treatment hospitals across the province who are either treating the current screen positive individuals or will partner with other specialists there for new diseases as we screen them. Pan-Canadian Genome Library is where the data will be collected in the end. And this is an important initiative in Canada in terms of developing these databases. Genetics Advisor is our consent platform and education platform for parents. We have, and I'll speak to it in a second, we're working to make sure that we can respectively include Indigenous groups, both in Nunavut as well as in the other provinces. And in doing this, have partnered with a number of different groups. We have a marketing firm that's working with us for consent. So again, the general population is being recruited through social media at this point. We have a number of funding partners, as you would expect. And then finally, and probably most importantly, we have partnered with all of the many groups across the international other genomic newborn screening groups. Why reinvent the wheel? These guys have been doing this, some of them for a couple of years already. And so have been really important that we learn from them and we can start a little bit ahead of where they started. Okay, so we've talked briefly about what is this study doing. I wanted to also mention what are we not doing. So when you a brief step back. When you look at genetic variants, everyone has genetic variants in their DNA. The vast majority of these cause no issues at all, but obviously a small subset would then lead to disease. We have a way that we classify these variants by, there's the American College of Medical Genetics has guidelines, and they're on a ranking from benign all the way through to pathogenic. This is a scoring system. And so what we are not doing is we're not reporting out variants that are uncertain, likely benign or benign. Only variants where we're fairly confident that they would likely cause disease are reported. We're not collecting long-term follow-up data at this time. This grant structure is not such that we can do that. We're not reporting carriers. So if it's a recessive disease and you have one variant, highly likely a carrier, we're not reporting that. And certainly we're not eliminating the standard of care newborn screening. Babies enrolled in this study would have already had routine newborn screening, and then they're in addition going to have genomic newborn screening. Okay. I mentioned briefly that we are working to be able to respectfully include Indigenous peoples. The Pan-Canadian Genome Library has also identified this as a very important area, such that they're trying to make sure they respect the rights of Indigenous peoples of Canada in developing new informed consent and self-determination control of their own data. And so we're working with PCGL as well as Silent Genomes Project. And they've partnered to be able to provide Indigenous individuals and communities participating in research with the option to have their data held either under Indigenous protection, governance, and oversight. And I know Kim Boycott spoke to this several grand rounds ago, and so you've got some more background there. In terms of how we're doing this within our study, in addition to obviously being part of PCGL and we are collaborating with Silent Genomes, we're working with collaborators across Nunavut and as well as some other advisors that we have engaged with to be able to hopefully set up a screen that's culturally sensitive in terms of do we need to offer different diseases? Do we need to alter the variants that we report? Do we need to alter how we are then contacting those families for treatment, et cetera? And so this is still well underway, but certainly want to acknowledge all of those who are helping us to be able to set this up. Okay, so the first objective is to develop a genomic newborn screening approach. When we do diagnostic NGS testing, I'm sure you've all heard about this now for years, we've done this for a very long time and we're quite good at it. We have often you're starting with either a genome or an exome. You have about 20,000 total variants. You can filter by rarity, use a number of other things like inheritance pattern, the patient's phenotype, et cetera, to then identify the one or two disease-causing variants. When we do this in a genomic newborn screening approach, this won't work. You don't have a phenotype. We don't have any information about that individual. The vast majority of those individuals are actually healthy and there's nothing to find. And we really can't assess all these variants by hand. To give you a sense of throughput, that 150,000 a year in Ontario sometimes actually translate to 2,000 to 3,000 a day on a heavy day when there's been a long weekend. And so your typical lab, that's a volume for a year for a diagnostic lab. It's the volume for the year for our diagnostic lab. And we need to be able to process that in a day. And so we need new strategies. And so we're doing this through a targeted gene panel, meaning there's a set of diseases only that we're targeting. Again, fits within the newborn screening principles. We're not testing for everything. We're only testing for what we can treat. And then in addition to that, we have what we're calling variant logic. So essentially, when a DNA variant is identified, there's a set number of criteria that it has to meet for it then to be flagged as of interest. We'll talk about that in a second. Okay, so workflow on the left. How do we come up with this set of gene list and criteria? The first was to establish a panel of experts and use this panel of experts to then develop our gene selection criteria as well as our actual gene list. So this is our gene panel of experts. Certainly many, many thanks go to them. Melanie Lecaria led this group in developing our gene list. And so there are both disease matter subject experts that are on the right here, and then a core group, some of which are international collaborators from other genomic newborn screening groups. And you'll recognize some of the other individuals at the bottom who are CHEO physicians and other CHEO collaborators. And so this was our group that then we looked at what should our gene panel be. So the first step was to develop what is our criteria. So the first criteria, this is our criteria list. We need substantial evidence that gene causes the condition. Makes sense? The disease gene-causing variants need to be reliably detected by our sequencing methods. There are certain types of DNA variants that are not reliably detected by NGS. An example is an expansion. So there's some diseases that are caused by expansions. NGS is not going to reliably pick that up, and so we can't screen for it by this. For genes to be included in our panel, the condition must have a disease spectrum that includes reports of children who develop symptoms under the age of 5. We need to know that earlier pre-symptomatic intervention for the condition has been shown to lead to improved outcomes. And then obviously the available interventions need to be equitable and accessible for all within our framework of the healthcare system. Okay, so how did we do this? There's now many thousands of known rare disease genes. We had to start somewhere, and admittedly, from the CPHI project grants, we had a very quick timeline. And so we started with a set number of these other genomic newborn screening projects, their gene lists, and there was exactly 100 that were unanimous among all of them. And so we took those 100 and adopted them. And then from there, we did two things. One is establish a larger set of genes to consider from more genomic newborn screening projects, and genes were considered if they were in at least 45% of those, and there was 27 considered. We also then asked for nominations from any of the physicians within our treatment catchment areas, and there was 27 that were nominated, and those were considered. And so in the end, we have a list of 223 genes. Here's the clinical cohorts that they belong within. And I'll give you just the breakdown here so you can see. So the majority are metabolic, which makes sense, but there's many from other areas of care. Certainly this gene list we view as version 1. We have said that we will reevaluate on a yearly basis. And so genes can be nominated either by contacting us through the website or really just contact Neal or I as well. Okay, so our objective 1, we have our gene panel. Now we need to know how are we identifying any infants who could potentially have disease-causing variants in those genes. And we've done a number of things. And so variants of interest, ways that we can identify those. We have variants that we know are pathogenic from either clinical databases or our in-house databases that we've developed through diagnostic testing. There's also known benign variants in those same databases. We have some in silico tools that can help us predict what a variant's impact on protein structure would be when we have things like population frequencies. And so at this point, our logic generates a list of variants that could be of interest, removes anything that's known to be benign, and then counts. If it's a dominant condition, do we have at least one variant? If it's recessive, do we have at least two? Or if it's X-linked, all but one of the X-linked conditions is we're only reporting in male, and so is it hemizygous. At this point, cases are flagged for manual review. So we've developed this variant screener, and it appears to be working quite well. Okay, the final part for this is we actually had to develop the work in the lab. So the other CPHI projects are being sequenced through these CGen sites, which are across Canada. We can't do that. They use DNA from whole blood, which is better quality than what we get off of a DBS, and no one's used to working with DBSs, but we are, and we've been doing NGS from DBSs from a very long time. And so we have two now very fancy high throughput sequencers in the lab. If you've ever been in the NSO labs, all equipment has names. We have competitions when they show up. And so our two sequencers are Mary Kate and Ashley. And so the lab has already developed this. The metrics from our whole genome sequencing from DBS look great. We were then approved as a sequencing site. And the final thing that we're working on is actually just automating this so that we can increase our throughput. Right now, we can do 1 to 2 runs a week, but essentially, as I said, to be able to get up to scale of what we would need, not for the project, but to be able to implement this long term, we need to be able to get up to a couple thousand a day. And so we've started at a small scale, walk before you can run, and everything is looking great. Just briefly to touch on, there's obviously a lot of informatics support that's required in the back end for this to work. We have a REDCap database that is involved in consenting with patients, and we've also built all of this into our custom LIS at NSO so that patient samples can be accessioned and their sequencing and resulting is tracked that way. And at that point, that's the development up until this, and we're ready. And I will pass it off to Neal to talk about the next parts. I'll stop sharing.
Great stuff. Amazing.
Okay, do I have the right slide up, Kristin?
Yep.
Okay.
You're good.
All right.
You're good. Thanks, Neal.
So that's the plan for the study, and now how do we get the patients? So objectives 2 and 3 of the study are to test test two cohorts of infants. 9,000 are general unselected infants, and 1,000 are going to be Ontario infants who were previously positive on the standard of care or the regular newborn screen. At present, we launched cohort 2 first, and the reason we did that is so that we could carefully control the flow of patients into the study initially. We've actually completed the sequencing of 39 of the patients and have resulted them, and we'll show you what those results look like just to sort of give you a taste of where we're going. And we've just started the open recruitment about a month and a half ago on March 30th. So going in order by cohort, this is for the unselected population. We had to pick a strategy for how we were going to present this information to new parents within Ontario. The most efficient way we decided to do this was not to get REB approval at every delivery hospital, because that would be very challenging, but to try using social media initially. So we partnered with National, who's a PR firm, and they developed a strategy for us, and that strategy is now live and being presented on Meta platforms and Pinterest. These are just examples of our advertisements. We hope that people are able to see these. It's sometimes a little difficult for us to tell whether these strategies are working, but we're working with these guys to figure out how to expand the reach. We're also considering other approaches to recruitment over time. Cohort 2 recruitment doesn't rely on this strategy because cohort 2 recruitment, as you'll see, relies on us contacting people who've already screened positive. So we're monitoring our social media. We are reported to have about 4 million views of our advertisements. We're like an anxious teen looking at our posts to see if you liked us and to see if you have comments on us. We live and die by little dribs and drabs on Facebook at this point. What we're really looking for here is negative commentary. There's obviously an opportunity for people to be alarmist about this project, and we want to make sure that we're not getting alarmist comments on our advertisements. At this point, we're leaving our advertisements open for commenting because we're hoping that that will expand reach. But we will shut that down if it turns out that people are putting up the government is trying to steal my baby's DNA images or things like that. Once people have seen our advertisements, they can be directed to our websites, and we use websites to bring people into the study by registering their interest. This allows us to capture a little bit of demographic information about them, which we need to go to the consenting stage. Basically, when people register an interest, they get an email back from us immediately saying that we're glad that you're interested in the study. Here's how to sign up. Once they register their interest, they're directed, I may have my slides out of order a little bit. Let me just briefly tell you about cohort 2, actually. So cohort 2 is going to come in at the next stage. So these 1,000 infants are positive by our standard of care screen in Ontario. We are excluding the patients who screen positive for things that don't interface well with infant. This includes the point of care tests for heart disease, things like the biliary atresia screen at home, hearing screening, and CCMV screening, which is non-genetic. Also CAH, because CAH is one of those genes, the major gene that drives it, that isn't easy to sequence by our approaches. So we exclude that. In cohort 2, we're taking all comers. We actually want people who are truly positive for disease, but we also want false positives. That is, people who we screen positive, who turned out not to have disease, because we're looking for the concordance. We want to know, do we get the same answer from infant that we got from the standard screen, and why? Why do we see differences in them? During molecular analysis, to the best of our ability, we are blinded to the outcome of patients. There are limits to this. There are only so many molecular scientists we have working, and sometimes our molecular scientists will know that they have seen this variant before, because they have actually done the diagnostic work for the patient. But to the best of our ability, they're not going and looking up the patient as they're trying to determine whether to make a referral or not. So here the goals for cohort 2 is again to look at the concordance and consider how early genotyping would augment the early care of patients who are screen positive on the standard of care screen. To actually consent into the study, and it's important, probably the most important thing to know about this study is you must consent to be in the study to do this. NSO is not simply raiding its store of dried blood spots and sequencing. We would never do that. We need permission from the parents in order to proceed with the sequencing. So we partnered with Genetics Advisor. Genetics Advisor is a University of Toronto spin-out that actually has supported other GNBS programs. And this website is used to provide education about the infant study and to allow people to consent online. This is great for us because it lowers our workforce requirement. Obviously, if we're recruiting from across Ontario, it's very difficult to situate people at every hospital. And it also allows people to reflect on the recruiting materials and the educational materials in the privacy of their own home and consider whether they would like to sign up or not. People can come and go to this site. They sign up and create an account so they don't lose track of where they are. So we have educational modules that tell you important things about screening. There's a way to ask us questions. If at any time somebody gets stuck, they can always call us, email us, and we will reach out to them with a genetic counselor to answer their questions and guide them through the process. Now we're going to turn to the concept of reporting. So one important question is, how often do we expect to screen somebody positive? So based on prior GNBS study, we expect a positive rate of about 0.3%. And this number is important to think about in context. Very early GNBS programs did things to artificially inflate this number. In fact, the first study of this type, which was run out of New York by Wendy Chung, included some things that really were very likely to be seen and really are not things that we would typically screen for. And the two excellent examples of this are G6PD deficiency, which is not screened for, is a very common X-linked condition. It's not considered to be highly pathogenic. It's really so common in some ethnic backgrounds that it's almost considered to be normal in those populations. And you don't want to screen for it. It really doesn't meet screening criteria. The other one is a mild variant of the galactosemia phenotype called Duarte. And Duarte patients don't require any care. And newborn screening programs actually go to extensive lengths to avoid picking up Duarte galactosemia because it's an annoyance to family and doesn't help people. So very early studies had positive rates that were over 1%, which really was good for promoting the idea of GNBS being incisive, but is actually bad in a public health program. You actually don't want to recall that many people because you're just wasting people's time and you're wasting money by doing this, and you're not actually improving health. The way we're going to report results is if we find a risk for a panel condition, we contact the family using our genetic counselors, and we work with specialist providers throughout the province to figure out what's going to be the follow-up steps, and we transition them out of the study and into clinical care. We've established expert advisors for each of our genes, but not treating physicians in all of our regions due to the low likelihood of any particular gene coming positive. We will basically be using a phone a friend strategy to identify care providers throughout the province when we get positive results. The cohort 2 patients are very likely to be positive, and they're excluded from that 0.3% because we already know that many of these will have monogenic metabolic disorders principally. And there, we work directly with the RTCs and just provide the results back to them. We always also provide the results to the family, and the family can pull down these results actually from the Genetic Advisor platform so that they can have a copy themselves. They can also obviously talk to us about their results when they receive them. This is just a sample of our results here for Harry Potter and Fred Weasley. A negative report is shown on the left, which just says that you're screened negative for all of the condition, and a positive report on the right with some fake gene names. You can see that we're careful in the language in these letters. We never say in screening that you have the condition. We only say that you're screened positive or you have increased risk for a condition, because it's really the role of clinicians who are evaluating the patients in the context of medical information and an exam to decide whether someone has disease or not. So, just to give you a sense of the early results, I said again that we had 39 samples that we have taken all the way through the process. We have more samples that are in the hopper at some point in the sequencing pathway. Most of these samples were from cohort 2 because these are mostly from January, February timeframe. In this, we knew that we had 15 true positive infants, 16 false positive infants, and 7 who were non-genetic. That is, most of these actually had forms of hypothyroidism that often is non-genetic. The results of these with an infant is that 12 of them were screened positive, and they were all from the true positive set. 26 of them were screened negative, which is about what we expected. There were 3 false negatives, and it's important, again, for us to look at why these are false negatives. 2 of them had variants of uncertain significance in the gene associated with the disease that they have on the newborn screen. And this is a known weakness of GNBS platforms. We have to cut the line somewhere. We excluded variants of uncertain significance, and we did this because if we include VUSs, we're going to get a lot of things that we don't want to see. But this also means that sometimes we are going to miss a VUS that's actually causing disease. And that was the case for 2 of the infants in this first run. And then one of the infants has a classical metabolic condition, biochemically confirmed, and we don't see variants. And again, this points to another reason that we can never give up biochemical screening entirely, is that we don't always find the variants when we do sequencing. So we know that child has the disease, but we do not know the variants causing it. We also had a single cohort 1 patient. You always learn things when you're doing a study. We had not thought appropriately about twins. And so we had a mother who was the mother of twins, one who was a screen positive infant and the other was not. And she wanted both of her infants enrolled. So, of course, we enrolled the second infant, and that twin was screen negative, which was good. So, other features of the study, just to give you sort of a quick list of things that we're doing. A subset of our samples are going to go through an untargeted metabolomics study. So 1,000 of the samples only from cohort 1. And Matthew Henderson, who is the laboratory director for NSO, is going to be leading that project. As Kristin mentioned, the gene lists are not static. They will update annually. We want feedback from patient groups, but mostly we want feedback from people like you, providers, on what you think would be important to screen. It's important to recognize they still have to meet our criteria, so we're going to review these. And we do accept public referral through an available website. We're going to actually drop that in the chat for you during the Q&A, but it will also be in this slide presentation. If you look at it, you can go to the form. It's very quick to fill out. We don't ask you a lot of questions. We do the legwork on figuring out whether the gene disease pair should be included. We're also working to establish additional follow-on grants, looking on how do we optimize the experience for families. This is new work for Canada and really kind of new work across the world. And one of the very important things is to figure out how to make this palatable for families. So working with Robin Hames, we were going to start writing grants to start understanding parent acceptability. And then one very important feature that Alex alluded to in the introduction is, in questions before the talk, is economics. And I'll talk a little bit about economics in a couple of slides, but we are seeking funding for analysis of what this would actually cost in a true public health program that is not a research study. Finally, just to echo the CPHI component and how we use the Pan-Canadian Library, CPHI is trying to produce information about the total genotype of Canada through a 100,000 genome study. We are one of 12 CPHI projects. There's another CPHI project here at CHEO, led by Kim Boycott, and all of these projects will eventually contribute their data to a Pan-Canadian Genome Library. This data will include a lot of information that's non-identifying and will be available for future research studies after review by a data access committee. So, to the end of this talk, we're just going to consider the past a little and look a little bit into the future. Why are we doing this? How does this fit in NSO's journey? So newborn screening's last big revolution, and we've talked about this already in this talk, was the incorporation of tandem mass spectrometry. And this is actually foundational to the start of NSO. NSO was really started to incorporate a technology that really sadly had been available throughout most of North America, just not in Ontario at the time that NSO was founded. Tandem mass spec greatly increased disease coverage. It had a significant cost to start. So the initial buy-up to do tandem mass spec was very expensive. So healthcare systems had to invest a lot of money to expand, hire people, but it gave a much larger data set and provided much better coverage for the population than the screen before. Again, Ontario only had 2 diseases on its screen prior to 2005, which is a very limited screen. This revolution was a huge success for newborn screening programs. And in fact, individual diseases that we screen for, like MCAD, probably pay for the entire screening program. And the fact of the matter is that programs that never took the step to tandem mass spec, an outstanding example of this is actually England, which has one of the worst screening programs in the developed world, have really lost out on an incredible opportunity to improve health and reduce the cost of care. Now, though, it appears that the emergence of large-scale sequencing is inevitable. There are so many of these programs, and they have been successful, and it looks like these are going to emerge. And in fact, the first public program, which is in Dubai, has launched. So that program is real, is live. It is different from Western programs in many ways in terms of the population covered. They only cover citizens, which is a very limited population within Dubai. And Dubai is also just a different place. In Dubai, you actually have to do genomic testing in order to get married and have children legally, and that's obviously something that's not palatable within Canada. So it fits more into the way that they manage patients. But in these considerations, we sort of have to think about how this is going to work. Our goal, we want to be clear, is to transition this from a research study to the full population as soon as we possibly can. That is why we are doing this. We are not doing this out of pure scientific curiosity. We think this is going to work. We think this is important work. And we think that the failure to adopt GNBS at this time will hurt Ontarians. So long term, there will be cost savings from this program. It's going to offer low cost and rapid diagnosis. Critically, it will introduce therapies at the earliest moment when they are most effective and lowest cost. So many of the advanced therapies coming onto the market need to be given as soon as possible. SMA is an excellent example of this. So SMA screening, which NSO is very proud to be the first place in Canada to have offered this. The therapies are amazing. but they have to be introduced extremely early in order to work, and literally days matter in these therapies. So if you don't screen for them and you wait until symptoms to develop, you're often going to be too late. The opportunity here is over the long run to greatly reduce the costs of care within the public healthcare system. We also know that there's going to be the ability to open our data sets, that is to reutilize our data sets within a limited time window for traditional untargeted diagnostic exploration. That is, if you have a NICU infant and you want to do a genome study on them, the data will actually already be there from the newborn screen. You don't need to resequence the sample. You can just pull our data and reanalyze it. So that's going to be one of the other cost savings we're going to offer. These ideas are all consistent with Ontario and Canada's goal to use scientific innovations to improve health. So, what are the problems? So the first obstacle, probably the less important one, is money. So our project, we'll just put the money here on the table and we'll all talk about it, uses $12 million in funding to test 10,000 infants. And that is roughly 7% of the birth population of Ontario for 1 year. And our project is a 3-year project. So this project is not cheap. It's fairly high cost. But this cost doesn't scale when you go up to the full-size population. Like with the mass spec revolution, we need initial infrastructure investment in order to run long-term. You don't have to buy new sequencers every year. Mary Kate and Ashley will continue to work for us for some time. And you need at least one sequencer to sequence, but the number doesn't scale. These sequencers are very fast. They're very effective. We do not need 15 sequencers, which would be the scale up from the 2 that we're doing, in order to do the project. And a final point is we're doing this in the Genome Canada context, but we don't have to use whole genome sequencing. We can use other forms of sequencing, which may allow us to lower costs considerably. It's hard for us to estimate the actual cost of operating the program right now, but we can give you a back of the envelope calculation, and it's roughly that it will cost somewhere between $300 to $700 per infant in about 3 years. And the reason that I say about 3 years is that the cost of the sequencing obeys the genomics Moore's law. It keeps declining and declining and declining. So the raw cost of goods is going down very rapidly to do these sequencing. The sequencers become cheaper themselves and cheaper to run. You can compare this to our current costs of sequencing using the traditional screen of about $170. So the costs are not outrageous. We're talking about maybe doubling or tripling additionally the costs of what we're already doing for Ontario and is already paid for by Ontario and is considered to be a good value by the province. Estimating the savings from the program is the hardest thing to do. So traditionally, you add screens one at a time and you think about the cost savings for just that disease. We can't do that when we're doing 223 diseases at once. There's no easy way to do this. And the entire community doing these genomic NBS programs is grappling with these problems. In 20 years, everyone is going to know that this saved a lot of money. Right now, it's hard to prove it. We just need to bridge the gap between those 2 points and convince our payers at Ontario that this is an important thing to do. And we hope to be able to do that. The second obstacle, and probably the more important one, is trust. Newborn screening, as you know, is a unique test from a privacy rights perspective. People do not consent in a traditional manner to do newborn screening. They opt out of screening. And our opt-out rate is about 0.3% every year, and we watch this like a hawk. We want to be sure that we do not have a loss of trust. The loss of trust by Ontarians would be our most critical risk. We worry about it even in the context of this research study. If people misunderstand and think that we are just randomly sequencing samples at NSO, we will have trouble. We also have to convince people that the data is safe. That is, we have to tell them how long we're storing the data and under what conditions. One of our big advantages is that we are one of the only sequencing GNBS programs that does our own sequencing. So everything is run in-house directly on samples that we have. The lack of movement of samples and data is a huge advantage to maintaining privacy. We know, however, that consent models may have to change, that the opt-out model may not work for this. And we're willing to look at and explore other consent models. Consent is very difficult for newborn screening programs because it is hard to get consent from people who just had a baby and make it truly informed consent. And we have to be able to offer the testing universally. So it can't just be that you can log in online and check with us later. It has to be some system where everybody can be exposed, like the newborn screening system is now. So in summary, GNBS is going to expand newborn screening to find way more treatable conditions earlier. Ours is the first comprehensive GNBS program in Canada, following closely in the footsteps of our international collaborators without whom we could not have done this. Our goal is to be family-centered. We are doing this project under informed consent, ensuring safety and clear communication with people, but we are trying to pave the way for the future of newborn screening. How are we going to do this for everybody in the future? And with that, Kristin and I would like to acknowledge our other partners, leaders on the infant leadership team, a lot of people at NSO who are critical to doing this study, and our collaborators in Newfoundland and Nunavut, other scientific collaborators, and the many people from programs who have helped us get set up and get started. If you're interested or have a new baby and would like to enroll in the program, that QR code is valid and gets you into the cohort 1 pipeline. And again, Sophie will pop our link to the nomination form into the chat of this meeting so that you can take a look at that and think about whether your favorite gene would be good for the infant study. And with that, we are happy to take your questions.
A wonderful job, Neal. Really an incredibly informative presentation by both. Makes you proud to work at CHEO, I got to say. Just quickly, to summarize the chat, both Marilena and Tom were wondering about primary ciliary dyskinesia being screened up north, and I think that Kristin has answered it off, saying that it is on the list, and Heather is off to clinic. And then Brian in the foundation wants to quickly know whether there's any foundation money used. CHEO Foundation.
I just wrote back to that one.
Okay.
No, but you're welcome to.
That's literally what I just wrote. We would welcome any opportunity to discuss that.
Yeah, we can always do more things with more money. And one of the big things we would like to do, again, is the economic analysis. So please contact us if you have any interest in funding that, or frankly, the patient and parent acceptability work, which may be more in line with what you do.
Yeah, good stuff. Suzanne Robinson wants to know, can we not go to the actual parents antenatally and get consent prior to the birth? Is that something that people look at doing?
So we cannot in the study. We worked with our ethics board on this very issue, and the ethics board made the determination, which is a totally reasonable determination, that since there was no requirement for us to consent prenatally, that it was better to have the child born. And that is consistent with consenting principles. This is always a difficult line to decide, and the REB did a good job of sort of thrashing through the issues, but they did ask us only to consent people after birth. We do have a mechanism on the infant study website to capture your information, have you give us the expected due date, and then we will contact you post-delivery so that you can enroll at that time.
I think Neal, she's mentioning that she's talking about in the future as well. I think that's something we'd have.
That's
a complicated.
That's a spicy issue, and we are looking at it. It's very important, but I was just answering for the infant study itself.
Muriel Clucci wants to know whether they can have access to the data itself. The parents can have access to the raw genome data. And my question is, what happens if incidental find anything like BRCA1 and stuff like that that you see or you do not see those? But anyway, can the parents get the data, the raw genome data for their child? Do they have access to it?
Kristin?
Yeah, that's a good question. I mean, we've had to.
I give the exact
in the context
answer.
of this project. We have dealt with it in other projects, and I think it would be on a case-by-case basis in terms of what are they hoping to
Actually,
accomplish with
so
it.
actually they can't.
They
Sorry, it's
can't?
a good point.
Okay.
No, that was a
There you
requirement.
go.
Yeah.
Okay,
Um,
there you go.
so
Um,
yes, we do not give back raw data to families.
there you go.
They agree to that in the consent form.
Perfect. Alex, your question, we won't see them. It's a
You won't see.
very filtered, targeted. We're only at the end of this ending up with ones that hit the logic, and even when it opens up for a manual analysis, it's filtered to a list that incidentals
Okay.
won't be there.
Christina. Christina Kenton, you have a question.
Good morning, everyone. Thank you so much for that presentation. It's absolutely inspiring and so impressive. I think about this topic always from the perspective of patients and families, and genetics and genomics is so, so complex to understand. And so I'm just wondering in terms of the offer. So it's from the family perspective as well, but also the providers who needs to be able to answer these questions. So this is from my work I did with Prenatal Screening Ontario years ago, is developing a whole suite of resources to explain this information. And that possibly is part of the pamphlets that you have prepared on the website. But language is so important in terms of that offer, right? Here's this opportunity. What does this mean for me? Because potentially this could be life-changing, right? When a family gets a diagnosis. So I'm really impressed with the focus I hear you saying on terms of getting patient and family feedback about the wording you're monitoring for that impact online, um, and also making sure that it's visible to other all kinds of families. So wondering if there's diversity of images that you have in your promotional materials. So just had that question about the patient family considerations.
Sure. So we would invite people to look at the materials. You can go through the process and see our website and explore it. We did use a diversity of images in order to accurately represent the Ontario population as we were preparing this. We worked closely with Genetics Advisor, who again set this program up in Australia. We had to remove all the Australian actor speakers from the presentation, but and localize our accents. But it's very important to us, and it was important to the REB that the explanations be clear.
I'd also say the images in our presentation are not the ones on the website.
They are
If that's
not.
where the diversity comes from, the presentation is admittedly my child. It was images I could get of at the actual newborn screening process. The ones on the website are many diverse families, and it's not actively during the newborn screening process. That's the what's here.
We forgive you your nepotism. It's a very
Well,
understandable nepotism
if you
for
need
sure.
photos of certain things, there's a couple convenient times to get them.
Yeah. Well, and I'm just thinking too, like we have some very powerful and impactful groups that provide consultation and feedbacks. Even the Champlain Maternal Newborn Regional Program has a family advisory committee, so you can really start leveraging those groups and they're so good to catch wording and images and like how does that land for folks? So anyway, happy to have a chat offline. And thank you so much for all this work that you're doing.
Heather Halley's wondering, thanks very much, Christina. Heather Halley's wondering if they can look at later treatable disorders. They may already be on the list, but wondering if you're going to add those to the list. Conditions that are treatable maybe in the third and fourth decade? No,
They're not.
Neal shake. No.
It
Okay.
5 years is the
Yeah.
cutoff that's for
Their
now.
age, their age in
Certainly,
this sense. Okay.
in the future, in whatever world, who knows what will happen if there becomes adult screening programs, etc. That is not at all within our domain. Our cutoff is there has to at least be cases that present within the spectrum of that disease in the first 5 years.
Okay. And you have a question.
Oh, so yeah, I just say same thing. 5 years is the end of the newborn screening window
Yeah.
for traditional studies.
Yeah, at some point to be open to discussion as the technology matures, etc. Yeah. And sorry, Anne, you disappeared.
Camera's like going on the ceiling.
Very good. It's okay.
Oh, that was fantastic, and it's so exciting for Newborn Screening Ontario. I had a question. I'm actually involved with the Beacon study in the States. So they're doing also like it's another NIH funded from the from different public health newborn screening, and so like part of the immunology. So we had same thing curated a very long gene list. They had like I think 40% of their genes are actually immunology. So they're developing these action sheets so that each disease is associated with a list of interventions. But what we were discussing at a meeting recently is just some of them are a bit more challenging from immunology perspective and very highly specialized. The thing I brought up from Canada is obviously like we have a larger territory or geographic challenges, and more specifically in Qikiqtaaluk of Nunavut. So just wondering, for immunology, but also the other disease, if you're phoning a friend, but are there kind of like pathways for access, and definitely challenging for the North having to bring down. That's one of the criticism of newborn screening for SCID, because it doesn't actually have that programmatic equitable services, I guess, for those children who have to travel thousands and thousands of kilometers for care. So it's a bit of a long question. I don't know if it makes sense.
I would say we're moving very slowly on the Nunavut project because of a variety of factors, and the access to treatment is one of them, and also the protection of Inuit data is a huge issue. We feel it's critical to offer this study in Nunavut if we possibly can. It is another form of discrimination to not try. But we are working very slowly and with a huge range of partners in Nunavut to offer the program there. And yeah, access to care is very important. And access to care is one of the reasons why our gene list is small in comparison to many of them. So you will note that the Beacons program gene list is something like 700 genes.
Yeah, like
ours is 230. There is a reason for that. We are not offering things where we don't have treatment. So unfortunately, if you have a high cost drug that you have approved by the FDA and is available in the United States, if you have not applied for approval in Canada, we can't put you on infant.
Okay, we're at time, and so Tom, you can have the last question. Thanks again, guys, for an amazing talk. And Alfred, we can talk about amniocentesis and NSO offline at some point. I apologize, but Tom, over to you.
Thank you. I'll be quick. We've had a couple of babies, especially neonates, where we've been wondering about genetic conditions, and we're planning to send off a panel to Blueprint or wherever, and we're told there's already sequencing available. We'll just run it on the sequencing. How does the sequencing compare to sending out a specific panel to one of these big companies?
The sequencing itself is sequencing. Once you have a genome, you have a genome. If you're just sending out a panel that's on an exome or a genome backbone, you could open the data and look at those same genes. If you're sending for any sort of specialized or looking at repeats, etc., that's where things will differ. But in terms of could you technically open this up? Yes, you could. And that's what Neal had discussed in terms of something that could be a long-term outlook where this could actually save money, is that if that child was found later to have issues, we could consider a pathway that you could open it up on a diagnostic basis to look at that data. But essentially, once you have a genome, you have a genome.
And can Tom use it that way faster, I think was the follow-up question, but you guys can have an offline talk about that. I see. Yeah. Okay. Amazing talk, guys. I'm proud to moderate it. Wonderful stuff. Well.
I'm gonna put the website in the chat. Someone asked for it.
Thank you so much.
No worries. It's on the NSO website too. If you go onto NSO's website, you can find it.